Hi, my name is Missy Carter. I'm with Critical Care Medicine with Virginia Mason Franciscan Health, and I'm going to discuss our new ICU specific RSI or intubation checklist. So what we hope to do by implementing this checklist is to improve the general flow of our airway management procedures. We're going to do this by creating a shared mental model with all of the team members who are involved with the procedure and make sure that we're all speaking the same language. Hopefully this will provide a safety net for our patients and empower all the team members to speak up when it comes to issues that could involve patient safety. So really we hope to, as well as reduce complications for our patient, we want to improve satisfaction for all the members of our team. So this is the one-page checklist, and I'll go through each component of this shortly. A little bit about the medicine behind ICU checklist. So a well-known ICU protocol for intubation is the Montpellier protocol. Recent studies have shown really good improvement with first pass success when we're using a more protocolized approach to intubation, and in doing so we have decreased complications. So this is a guideline, not a strict protocol. So it's an evidence-based guide that we're going to kind of guide our practice, get everyone on the same page. We're going to have this guidelines without removing autonomy or creating sort of a cookie cutter approach. Now there's two components here. One is the bedside checklist. So this is a tool that you're going to use. It's a memory aid. We're going to use it during the procedure. This will hopefully reduce our cognitive load and again, improve that shared mental model so that every member of the team kind of knows the flow of what's going to happen for this procedure. The written guideline is a little bit more detailed description. So this is something we'd use in training as we're preparing, as we're reviewing, not specifically at the bedside. This will provide the evidence behind this checklist and will help us have a better understanding of how we got to the checklist. So the patients that we won't use this checklist on are cardiac arrest patients. Cardiac arrest has much different treatment priorities, so we won't be utilizing a checklist in that scenario. And then the rare but crash intubation, where we don't have as much time. So crash intubations are actually not very common. This would be a situation like severe angioedema with impending airway failure, where I need plastic through the vocal cords and I don't have time to resuscitate the patient. So I'm taking some risk when I'm performing the procedure. Severe airway bleeding, so if you think about somebody with esophageal varices or persistent emesis that I can't clear with BLS maneuvers, or an active choking patient with obstruction to the airway. But outside of those exclusions, this checklist would be for all other intubations in the ICU. And specifically, we're talking about patients who are breathing and we're giving medications to induce them and paralyze them. Now, this could also be a patient who we're using a BVM on who's not adequately ventilating on their own. There's three components to our checklist. One is the pre-intubation component, then there's the peri-intubation and the post-intubation component. The pre-intubation is by far the largest component of this checklist. This is time where we're really going to optimize the patient, both physiologically. We're going to prepare the equipment and what we need anatomically for this airway. The timeout will happen once everything is prepped and we're ready to perform the procedure. We'll clarify the roles and we'll give the medications at that time. Post-intubation, this is when we're going to confirm placement and then we're going to reassess the patient for any hemodynamic compromise. And once they're further resuscitated if needed, then we'll resedate the patient. So let's go down the checklist in a little bit more detail. So there's essentially 6 points to this checklist. So for the pre-intubation period, we spend a fair amount of time stratifying pre-oxygenation. So at this time, we should be elevating the head of the bed unless contraindicated. Patient should be placed in a sniffing position, which is typically a towel under the head. And we're performing this pre-oxygenation for at least 3 minutes on 100% FiO2 to get nitrogen washout. Ideally, we'd like to get the sats as close to 100 as possible. Outside of a patient that we're needing to bag with a BVM, this should be accomplished in one of 3 ways. A non-rebreather set at flush rate, BiPAP, or high-flow nasal cannula. If we're using BiPAP or high-flow nasal cannula, we should have both of those set to 100% FiO2. when we're using a non-rebreather, we want to turn it all the way up. So not just till the ball stops, but until the valve won't advance anymore. So this should be pretty loud. We're going to consider apneic oxygenation, which is when we leave a nasal cannula in place running at least 15 liters per minute while we're doing the intubation. And then delayed sequence intubation is something we built in here for the patients that are really not tolerating pre-oxygenation, and we may need to sedate them for the procedure of pre-oxygenation. We may choose a medication like ketamine in this setting because we want to keep the patient breathing while we pre-oxygenate them, and then pushing the paralytics after the patient's optimized. During this time, the provider will perform their difficult airway assessment and get an idea of what their plans are going to be. Resuscitation is something that should be on everyone's mind. We don't have specific goals for blood pressures. We just wanted to remind everyone that anytime a systolic blood pressure is less than 100, we have increased risk of peri-intubation cardiac arrest. So we wanted to highlight this so that everyone in the room is aware to look out for this. Anyone doing the procedure or involved in the procedure should be able to speak up and say, hey, I see there's a low blood pressure. Can I grab your vasopressors? Would you like a fluid bolus? And then the equipment this is really RT driven. They have a long list of things that they need to get. There'll be collaboration and communication between the provider and the RT for this. But we wanted to give RT like a clear list of like what we want at the bedside for every intubation. So a bag valve mouse with a PEEP valve in place in case we don't get the tube on the first try. Oral or nasal adjuncts, and then suction, either Yank or large tip suction. Ideally, we'll have 2 working IVs, and then we've got either our colorimetric or our end-tidal CO2 ready to go for confirmation. The difficult airway kit, which has our LMA and our crite kit in it, should at least be at the doorway to the room, and then we should always have a bougie ready. RSI medications would be ordered at this time, push-dose pressors, infusion tongue, and then video or direct should be available, ideally both of those, with appropriate blades, stylets, or bougie. So once everything is sort of prepped and the patient's optimized, then we'll perform a timeout. So the provider would let everyone know there's a timeout, we're performing an intubation, here's my plan. So plan A, for instance, I'm going to do video laryngoscopy. If that doesn't work, my plan B is we're going to bag the patient. We'll put an adjunct in. If we can't bag the patient, I'm going to put an LMA in place. And if I can't intubate or oxygenate the patient, we're going to perform a cric. So that everyone in the room knows, hey, we have our plans and we're ready to pivot and move to the next plan if needed. And then we'll assign the tasks. So RT, for instance, will help with laryngeal manipulation. They'll have the BVM ready as needed. One of our RTs will be just monitoring the patient and their sats on the monitor, looking for any lethal arrhythmias, looking to see if the patient is bradying down. And then additional RN or the pharmacist will be at the bedside with the medications in hand. And then when we push the medications, we put some sort of general guidelines for doses here for induction agents. We listed etomidate and ketamine, but this isn't to say those are the only agents that could be used. Many people may use medications like propofol for induction as well. Now, we said we can consider a reduced dose in shock, but honestly, the evidence is pretty weak on this. I think the more important point is that we really resuscitate our patients. And then our paralytics, you'll notice we have kind of a higher dose of rocuronium here than you may be familiar with. This is because in emergent intubations, 1.5 of rock has been shown to have a faster onset, closer to that of SUX, so about 40 seconds to full paralysis. So you may see us ordering those higher doses of rocuronium. And then just a reminder that medications are pushed sequentially. We're not waiting in between the induction agent and the paralytic so that they have rapid onset and we can reduce the apneic period. And then lastly, once the tube is in place and confirmed with ideally end-tidal CO2 or colorimetric, then we're going to do a reassessment to see if we need to resuscitate further after the intubation. A general rule is we'd like to get these blood pressures every 3 minutes as the patient is likely to decompensate in the 15 minutes following intubation. And once the hemodynamics are stabilized, we want to get immediate post-intubation sedation on board. So this is kind of just an overview of what that would look like. So the provider at the head of the bed, for instance, is going to ensure that we're doing pre-oxygenation. They're going to be getting that patient positioned, head up, sniffing position, ordering resuscitation, and working with RT to make sure they have all the equipment that they need in place. And again, they will call the timeout, state their plans, and assign the tasks to everyone. RT has a long list of things to do. In addition to getting the ventilator set up and ready, glide scope in position, ET tube, hyperangulated stylets, lubed and ready to go, CO2 detector, and all the equipment we discussed earlier. RT is also going to be likely the one to help us with some dynamic positioning while we intubate if we need some crag pressure or additional head manipulation. They'll be securing the tube and then, of course, getting the ventilator set up. Having a RN just dedicated to watch the monitor and sort of the big picture during this procedure is really important. So the provider may say, hey, let me know when the sats get down to 90. Now that number may change based on the patient, but the idea is we don't want to be counting down from 100. Creating sort of more noise than needed, so we give you a benchmark. Also keep an eye out for bradycardia or lethal dysrhythmias and be ready to abort the procedure if the patient needs CPR or other interventions. And then RN or pharmacist who's doing the medication push. So after the timeout is called, the induction agent and paralytic are given without pause. And then after tube is confirmed, this would be the person to increase or start vasopressors if needed and get that continued sedation on board. Please feel free to reach out to me anytime if you have questions. Thanks a lot.